My name is Rachel Callender and thank you for joining us for today's Parliamentary Friends of Palliative Care event, Paediatric Palliative Care, A Pathway for Success. To officially welcome you all today, it is my great pleasure to introduce the co-conveners of the Parliamentary Friends Group for Palliative Care, the Honourable Nola Marino, Federal Member for Forest in Western Australia, and Senator for Tasmania, Katrina Billick.
Hello everyone. I'm really pleased to be with you. I'm Nola Marino, the Federal Member for Forest and co-convener of the Parliamentary Friends of Palliative Care Group. And I'm particularly pleased that the theme this year for National Palliative Care Week is It's Your Right. Now, the goal set for the 2022 campaign is to raise awareness of the rights that Australians have in accessing high quality palliative care when and where they need it. And today's event is focused on paediatric palliative care, which I know is so close to many of you who work in palliative care, and we all know why that is. I've recently lost in this last year a young great nephew who was just 5 years of age and required both palliative care in home and in the clinical setting. And I can see just how important palliative care is and when it's at its best. I witnessed why it's so necessary and the importance of tailoring the care to suit the needs of the individual and their family. So again, I thank you for joining us for this event today and being part of National Palliative Care Week. My colleague and co-convener, Katrina Billick, and I are both very committed to and passionate about palliative care, and we trust that you will enjoy the discussion today and take part in it as well.
To begin, I acknowledge that I'm hosting today's events from the lands of the Whadjuk people of the Noongar Nation. I also acknowledge the traditional custodians of the various lands on which our guests are based. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Western Australia. Today we are looking at a subject very close to my heart, paediatric palliative care. We have an ambitious and very worthy task in front of us this morning. We'd like to increase awareness and understanding of paediatric palliative care, what it is and why it is so important. Paediatric palliative care is more than you think. It is about improving the quality of life of infants, children and young people diagnosed with a life-limiting condition and supporting those who care for them. This event will discuss the establishment and development of paediatric palliative care in Australia, the challenges, the successes and the ongoing need to improve paediatric palliative care for all children and families. As part of our discussions this morning, we will showcase the development of the Paediatric Palliative Care National Action Plan project and highlight the co-design approach, what that is and why it is so important. The Paediatric Palliative Care National Action Plan project represents a unique opportunity to support health professionals to respond to the specialist needs of children with life-limiting conditions. The project will also address the needs of parents and carers seeking assistance to care for a child with high medical needs and life-limiting conditions. We have 4 guests for today's discussion. Sarah Fleming is the Chair of Paediatric Palliative Care Australia and New Zealand and a member of the Paediatric Palliative Care Steering Committee. Sarah Fleming was recognised in this year's Australia Day Honours for outstanding public service to the development and provision of paediatric palliative care services. Tim Rogers is the National Advocacy Manager at Red Kite, supporting children and young people diagnosed with cancer and their families. He has a background in social work, acute care and crisis work. Ryan Fowler, together with his wife Karen, founded the charity Rio's Legacy after losing his son Rio in January 2018. The charity, which has since raised $600,000, was established to assist children with life-limiting conditions and their families. Ryan received the Pride of Australia Award for service to children's palliative care services. Dr. Lisa Cuddiford has over 20 years' experience in paediatric palliative medicine in both the UK and Australia. In the UK, Lisa was instrumental in setting up a community paediatric palliative care service in Birmingham and was the medical director for Acorns Children's Hospice. After moving to Australia, she has led the WA Paediatric Palliative Care Service and is delighted to be associated with the development of WA's first children's hospice. Before we start this panel discussion, I would love our audience to have the opportunity to get to know our panellists a little better and for you to understand why they, and myself included, are also passionate about paediatric palliative care. My own story began when my little daughter Evie Amore Callender was born in 2008 with a really rare chromosome condition. And I remember the first words the doctors used to describe her, and they were so subtractive and deficit focused. The words added pain and trauma to an already terrifying situation. They used words like retarded, dysmorphic, abnormal, incompatible with life. But for every day of Evie's 2.5 days on this earth, she was completely compatible with life. So having Evie completely changed my understanding of living in the moment and living in freedom and making the most of every opportunity. She completely hijacked my career as an ex-wedding and portrait photographer, and I now work in Western Australia and around the world educating healthcare professionals on the importance of language, especially at a really difficult diagnosis time. So we'll talk a little bit more about that because this discussion will be really rich in how paediatric palliative care can make a difference in a family's life. Sarah, I'm going to jump to you first. Maybe you would like to share a little bit about yourself and how you became involved in paediatric palliative care.
Thanks, Rachel. You know, I came originally from a paediatric oncology background, and I had been working with children with cancer for some years. And really what happened to me in my late 20s was a sense of worry about what happened to families after they'd been in the bad newsroom and crawled off home with a child who wasn't going to survive cancer. And so I actually did some research. We did some research into what actually happened to families, and then started looking at families of children who had other diagnoses as well. And it made for fairly grim reading. And so, you know, palliative care was still in itself a new specialty, and the thought that children died was something that no one wanted to know about. But the reality of what happened to families was something that just couldn't be ignored. And, you know, they wanted to be at home, and, you know, they didn't want to have to come into Paed Emerge every time they needed something. And so it just, for me, just was this evolving thing. And I thought I might do some studies and see if there was anything else that I could learn. And it sort of just rolled along from there because, you know, it was a long time ago since I was in my late 20s. And, but it did... For me, it just came out of the suffering of the families and seeing what they went through and knowing passionately that didn't need to be so, that they didn't need to suffer from lack of support, lack of knowledge, you know, just someone on the phone to say, no, you can take the dose up. You know, and that sort of thing, I think, got me into it. And then luckily the whole enormity of it didn't happen at the same time. It sort of was incremental creep, and it just never stops that you can do better.
Thank you, Sarah. I love your passion and your energy and how you identify this as an ongoing journey of learning, and that we are making inroads in this really important space. Tim, I'm wondering if you can share a little bit more about yourself and how you became involved in paediatric palliative care.
Yes, of course. I had a role in the late 80s which involved me a fair bit in adult palliative care. However, I came to children's palliative care when I became a ward social worker, paediatric cancer ward social worker at Royal Children's Hospital in Brisbane. And I was also Assistant Director of Social Work for the medical team. So I supervised the various social workers who worked with children across such a range of life-limiting illnesses. And obviously in that circumstance, we became very involved with families. Thankfully, we were able to be involved for quite extended periods. It wasn't just that brief acute work. Saw that there was so much that could be done that could improve the experience that people were having. So that was began in '94, and I kept doing that within the health sector through for about 10 years, but have really stayed in the space ever since then. So after I left the health sector, I moved into not-for-profit, so back into the community sector, which is kind of where I started, and still specifically in paediatric oncology, working for Red Kite. And there I had the privilege of building our programs of community support, and we built them in a way that we could hopefully reach right into people's homes, stay with them across the whole experience. So not all of that involved palliative care, but a significant amount has, and it's just always been an area. Oh, gosh, Rachel, and the things that you said at the start are part of the reason that it has remained important. There is so much work can be done, sometimes in simple ways, just through language, sometimes in more complex ways. But yeah, it's been a place of passion for me and the people I've worked with since. So.
Yeah, wow. Thank you so much, Tim. That sounds like incredible work that you're doing, and I can't wait to hear more from you as we continue this discussion. Ryan, I'll jump to you next, and maybe you can share a little bit more about yourself and how you became involved in paediatric palliative care.
Thank you, Rachel. Look, how we got involved was through my boy Rio, really. Unfortunately, he got a terminal illness that we had never heard of. The doctors had never heard of, and this was in late 2017. And up until that stage, you palliative care. I went through that with my mum and things like that. And when you hit with that as a father, it's a big thing. We went to hospital. My son had gastro, and we never went home. So we're on a journey from that point of view, and we were fortunate in that regards that we went to a place called Bear Cottage, which is a hospice here in New South Wales, and that really changed my focus on palliative care, from what I experienced with my mum to what they did for my family, or my daughter, who was 4 years old, watching her brother pass away. And something that really stuck with us, they said, children come here to live, not to die. And since then, it's been a big passion, because there's not a lot of these hospices in Australia. And so, yeah, since then it's been a big journey of going through our grief, but then starting a charity to try and raise more awareness, support and funds, and hopefully build more hospices and get more out there like everyone's doing here.
That's beautiful, Ryan, and I completely agree with you as well. And I think it's amazing. I don't know if you feel the same, but I find it such a privilege that I get to share my daughter's story with so many people, even now after she's passed away, and that kind of keeps her learning and what I've learned from her and the spirit of her alive, and that makes a difference. That can drive forward thinking and forward focus and really powerful positive change. So I get that sense in your work as well, so thank you so much for sharing. And Lisa, can you tell us how you became involved in paediatric palliative care?
Thanks, Rachel. It's interesting, actually, hearing other people's sort of stories and journeys of getting involved, and seeing some similarities there, because I was in the UK training as a doctor and actually thought I wanted to do paediatric oncology, and then heard Anne Goldman speak. And Anne Goldman is a consultant in paediatric palliative medicine at Great Ormond Street, or was. She's now retired. And I was absolutely blown away by her discussion around quality of life, and how it really made me stop and think about how I had been focused on the illness. And then it was like a veil came off. It was, that I could actually focus on what was really meaningful and important to the child and family. And she had a great saying that was around adding life to years, not necessarily years to life. And I think that underpins everything that we talk about in palliative care, about quality of living as well as quality of dying and grieving, but that quality of life. And I was hooked. And so as a registrar in the UK, I started to look at, well, where do children die? And yes, children do die within the oncology setting, but actually the majority of children come from outside those settings, children with complex needs. And so actually I used my training in the UK to gain experience in those areas that would give me the skills to do this as a career. then we came to Australia, and everything was uprooted. It was all so different. I did settle my kids into schools, etc. So I actually waited a couple of years, and then was really lucky enough to come and work with the WA team, and really begin to see the challenges that this so huge state poses on providing equitable care, and also looking at the sort of care that was delivered. So really sort of campaigning alongside many others around hospice care. And so I feel that I've kind of been drawn and pulled by great experiences, meeting amazing colleagues that I learn from, and then the best learning and my best development has come from the children and families who, I was sad when I heard you talk about the negative language, because that I think, Sarah, Tim, I think our experience is that these children and families, they make us buzz and sing because they are so vibrant and so beautiful, and we have such a lot to learn from them, and they have such a lot to give. So it's actually a really rewarding place and speciality to work in. So sorry, talk for too long.
No, it's lovely, Lisa. I can feel your energy and your passion just jumping out at the screen at all of us, and I think it's lovely. And I love that you touched on the word quality, and adding life to years rather than years to life, and even just the way all of you have mentioned life-limiting conditions rather than incompatible with life. And that's one of the things that I teach healthcare professionals, because then life is the focus rather than the incompatibility. And it's just that the simplest things can make the biggest difference. So it is such a pleasure to join this space with all of you, with all of your passion and expertise. Sarah, I'm going to ask you a question now. From your 20 years experience in this specialty area as a nurse practitioner, clinical service director and chair of PAPCANS, can you tell us what paediatric palliative care is, and provide us some insights about the establishment of and changes to paediatric palliative care in Australia?
It's always very difficult to find, a snappy sentence on what paediatric palliative care is. I tend to sort of go for the grab that says, well, it's about living life to the max and taking that out there in whatever facets you need to. But to me, as a service provision, it's about a combination of multifaceted skills and availability of different people with different talents and backgrounds and qualifications to actually build a nest for living in around a family whose child has a recognised condition or circumstance that says that their life is limited, most likely to childhood. And so to me, paediatric palliative care is then grabbing the dimensions, the specific dimensions of each family, and building the right nest around them, and thinking about the diagnosis itself, the personality of the child, the social personality of the family and the community they come from, the geographical location of where they live. What is this diagnosis and what's it going to mean? What are their actual individual needs as a family, as a core group of people, and how do we work with that? And transporting, getting the right responsiveness and the personalities and the communication, and I guess the working alongside and working with, because none of this works unless what we do is follow the lead of the family and, not drown them in responsibility. We don't want to dump them in it, but we do want to develop, the partnership with them. So to me, the provision of paediatric palliative care is, what is the dynamic? What is the description of the family in front of us? And then what do we build around? What do we need to pop in there to make it work, or go find or grovel or beg or whatever to put it all in place?
Yeah, I love that. What a beautiful analogy, building a nest around a family. And I love that because it does take into account the nuance and the differences that each family might have. You're not building the same shape, like nests are all different shapes and sizes, but that sense of being held and being cozy and being wrapped around in love and care and warmth and support just sounds really powerful. And it's something that I didn't have as a mother, and as I reflect, and I have been reflecting on my own experience through doing this work and preparing for this conversation, I remember feeling so alone and so isolated, and even so alone from my own husband. Like, the way that we dealt with it was so different. We couldn't talk to each other about it, so there was no nest, there was no safety. And I remember planning my daughter's funeral when she was still alive and not having any idea about, is that normal, is that okay, and kind of freaking myself out and being really alone in my grief for the whole lifespan of my child. And then we entered actual grief as well. So it's so important to support these families like this, because there's so much that you hold on your own otherwise, and that really impacts on how you experience life and experience every moment with your child when you want to make the most of every opportunity. So this work is so incredibly important. And I'm wondering if I can throw this question to all of you, and you can just throw your hand up when you're ready to answer. But what are some of the common misconceptions that people have about paediatric palliative care? Lisa?
I was just going to say that we see paediatric palliative care as being alongside the family and partnering with the family, and it can be for many years. So I think that's one difference within adult practice, where it is often more that end-of-life practice within adult palliative care, whereas we will partner with families. And I often feel, I'm not quite sure how it's going to work on Zoom. I use my hands a lot. I'm so sorry. But it is that families describe their journey as being a roller coaster journey, but actually I also see that what we often do in palliative care in children is work alongside them, really intensely support over time, and then intensely support again close to the end of life. But actually what's important is that we're there continually. And I think part of that is that children develop. So how their illness affects them may change. And so that changes both in terms of their cognitive ability, their physical changes, the effect that drugs have on them, how they manage to absorb, how quickly, how they metabolize them and excrete them from their bodies. So that sort of need for us to be working alongside is really there, right from diagnosis all the way through. I think that the fact that often these conditions are rare, and both of you have talked about your children having rare conditions, means that there's not a big cohort of people that understand what's happening. So it's really important for someone to not forget the illness, but remember the child. And what is the effect that the illness is having on that child? And so, often when families are mentioned to me, I can't remember the illness. I feel like a bad doctor sometimes. I think, I have to go and look the illness up. But I can picture the child. I know the problems that illness is having on them, but I just can't name the name because it's a little bit unusual. So I think that sort of those rare conditions, and sadly, sometimes they run in families. And occasionally they present a little bit later. And so families haven't had a choice to think about whether they want to go ahead with a pregnancy. But even if they do know and they do go away, they do go on and have future pregnancies and have more than one child with the same condition, then that I'm going to use the word burden of care, and it's a burden that's held with love by families, but it is a burden of care in comparison to what I needed to do for my children, is really, really exhausting for our families. So I think that's another thing that, you're their teacher, their nurse, their paramedic, their doctor, their physio, their OT. If you are the parent of a child with a life-limiting diagnosis, you have all of those roles. So I think that the differences are huge.
Yeah, thank you so much, Lisa. Brilliant share, thank you. Tim?
Picking up on all of those themes that we've talked about so far, and particularly that it is not just end-of-life care, I think a real misconception is that palliative care happens in hospitals and hospices. It happens in neighbourhoods. It happens all over Australia. There are children living with life-living conditions everywhere, really. And I think a corollary of that is that the good palliative care experiences for families is not just about the specialists and the experts that come in, and we'll talk heaps about that, but that everyone can have a place to a role to play, if you like, within friendship groups and communities. And I don't think there's a family I've ever worked with who hasn't told me about the kindness of strangers, the person in the community who sort of came out of nowhere and did something and made them feel less alone or more cared for, either in the palliative phase of palliative care or including in the bereavement phase of palliative care. I think we mustn't lose sight of bereavement as part of the palliative care journey. And families often do feel quite isolated and alone at that point as communities struggle to understand their pain and their grief and how they express their love in grief. But it's such an opportunity for communities to be inclusive, because it's not just about hospitals and hospices, but it's about neighbourhoods and streets and schools. And
I'm going to jump in and share something just on to your point of communities gathering around to express love and care during the bereavement phase when there is significant grief, because often people don't know what to say. There's so much you don't know what to say, and you don't want to say the wrong thing, and people end up falling to cliches, which can often hurt and isolate even more, so then the families just think it's easy just to hide away. But when Evie died, I remember there was a moment like I didn't know what to wear at her funeral. Nothing felt right, and we'd played the song Yellow by Coldplay, the beautiful acoustic version. And so yellow became almost like a symbol for Evie and for thinking and talking about her. And so I ended up buying like a little yellow cardigan to wear at her funeral. And since that day, like it's been she died in 2010. So almost, 12 years, I've worn something yellow every day. And it just became a thing. And then people knew this about me and about the connection to Evie. So it gave them a way in without them having to say anything. So sometimes they would leave yellow flowers on my desk, or they'd say, Rach, there's this beautiful yellow dress in the window of such and such shop. I was thinking about you and Evie, and you should buy it and wear it every day, just little things like that. But yellow, the colour, became this beautiful symbol of care. And I think the more that we can think about different ways of expressing grief and inviting people in, it can be so powerful as well. Yeah, Ryan.
So my son wasn't born with a condition. He was, as I said, we got gastro and then went to hospital, and then all of a sudden this happened. So we didn't have years and years of training, but the way Bear Cottage and places got around us, there was a tidal wave, and that continual journey was quite amazing. And we'd never heard of the life-limiting phrase before. I didn't know what that was talking about, what that meant. Because we hadn't had a child that had a condition or anything like that before. So we were hit with that tsunami. But then we went to Bear Cottage, and the amount of families that we met there who they're doing this for years. They're doing this for years in, years out. They've lost friendships, they've lost relationships, and the respite that they have. And that's touching on what Lisa said around that support that goes up and down, and we didn't know what we're doing with the medical stuff, whereas they did. And I think that's the big difference as well around that, looking at it from that point of view, because, we didn't know, we had no idea what to expect, but we were welcomed in with, and as I said, coming there to live, no matter how short or long their life is. And I think that's a big part, is that, it doesn't matter, there's no discrimination against any sort. It's championing these kids no matter where they are and where they've come from, which is amazing, and, what we're doing.
Sarah, any last thoughts about misconceptions?
Look, I think we've touched on them, but I think one of the essential ones, and I think, Ryan's already gone there, you have, is that very important delineation. Paediatric palliative care is not actually about the traditional way that people see end-of-life care. And we don't like the term very much because we see children as living until that time of death. And it's not about stopping treatment either. So that often comes with it, that it's, that families, they're not giving up hope just because they're working with paediatric palliative care. They're not stopping treatment just because they're just thinking differently about how that impacts on their child's life and their living in the meantime. And I think discerning it from a different lens.
I love that, Sarah. And as a follow-up question to all of you, when we think about what we learn from health professionals, services and academics, but having cared for and supported so many children and families with a life-limiting condition, what lessons have you learned from those people in this space? Lisa, I'll go to you now.
I think that lessons that I particularly have learned is the amazing strength and resilience that families have, and I'm not sure where that comes from, and I see it time and time again, and maybe it links into what Sarah was saying about hope. And about this refocusing of hope and this ability to keep looking at information, keep looking at your child and weighing things up that are in their best interests. And I think what I've really learned is how, as a parent, I think I maybe pay lip service to saying that I do what's in my child's best interests. I think when I watch the parents I work with, I see them put their needs behind their child's needs every second of every day. And then when there are really difficult decisions to be made, they weigh those up so well. And they are so challenging, the decisions about whether you may go for a treatment or not for a treatment, they're just incredible. So I think I've really learned to trust in parents. I think it's important for me to say that I don't always know best, but I don't want my own children to hear that. But I know that I don't always know best. And the other thing that I think is that when we meet families, what they tell us is how hard it is to retell their story when they're trying to get something. So I loved when you spoke about the fact that Evie is still in your life and Rio for Ryan, still in your life, major parts of your life. But when you have to retell your story over many years to get a service, or for people to understand, or when you come into ED because your child's not well, I think what I've learned is that we really need to support families in holding that story for professionals, so that families just have to update it, but not start all the way from the beginning.
Yeah, that's a really powerful point, Lisa. I remember there was a moment in our life with Evie when everything changed for us when I was listening to a healthcare professional. She was a senior surgeon at Starship Hospital in Auckland, and Evie had gone in an induced coma, and she had a trachea in, and things were looking pretty bad. They didn't know if they took the tube out that she was going to breathe on her own, and so we had some significant options in front of us. And she said the most powerful thing that changed my view on healthcare professionals from that moment on. And she said, just because we can do these things doesn't mean that we should. And she really made a point to listen to what our values were as a family. What was the point for us as too much intervention? Like, what did we feel was acceptable for Evie for her quality of the rest of her life? And we had to make this decision knowing that whatever we decided might be the thing that ended her life. But we had the power and the permission to make a decision. And she said the most beautiful thing. She said, whatever you choose is the best thing. You are doing everything you can for her, because parents feel so much pressure to do everything to preserve life that often the quality is lost of that life. And so to have a healthcare professional kind of hold us in that space and listen to the values of us was such beautiful partnering, which I think speaks to what you've just been sharing. So yeah, thank you. Ryan.
Yeah, I was just going to add on, and I think Sarah touched on this as well, around learning to continue treating whatever is going on. And that was a big thing we learnt, because you go to a place like Bear Cottage, which is amazing, and you go to these places, and it's about trying to make we heard it a lot at the stages when we were looking at places like this around comfort, trying to support and make sure the child's comfort and stuff like that. We had a few issues with that at this time, because what we felt like they were trying to do from a comfort point of view wasn't actually comforting Rio because they didn't know his condition and what was gone. And there was actually a doctor that we had, I won't get him over, with my wife when we were at Bear Cottage, who said, you know what, we need to tackle this different, and this is change. And it was that I think that really helped, especially my wife and I out a lot, because they still, even though Rio was not doing well and we knew that the days were shortening, they said the best way to comfort him was to still treat his illness, and they gave him the correct medicine rather than just to comfort him and make him not sleep more. I know that sounds really, but it's just looking at that we still need to treat the illness that he currently has. And that was a changing moment because our journey then became a lot. We were able then to be a family rather than watching him suffer. We're able to watch him enjoy what he had left with us. And I think that was a big learning curve in different areas and around that, that paediatric palliative care and talking to doctors, because the doctors were not that they were unsure, but I felt like at times they were just figuring out what was happening with Rio and then letting us know, because it wasn't like he had cancer or something that they'd already sussed out, if that makes sense. And that was a big thing for us, which was just jogged when we had this conversation.
Yeah, thank you so much, Ryan. Sarah?
Look, I think, for me, the journey with families has always been a humbling experience. I can never know the answer to everything. And I think, the great wisdoms that have come to me over time is to listen to families and then to let go, to actually let go of my assumptions, let go of what other people might have told me, and actually truly listen and hop in the trench with that family and how they want to do it, and listen. And if one family decides that they want to keep treating with this particular method or medication or whatever, and another family says we don't want a bar of it, they equally get our attention and our support, because this isn't my journey, it's theirs. And I love the fact that, Ryan, you immediately started talking about your journey as a family the minute you felt it was given back to you, that you could. And so to me, that's what I've learned from families the most, is to actually, yes, bring my wisdom and my experience with me, and sometimes be able to say, some families that we've looked after have felt that this is important as a suggestion, but not to be directive, to actually, that you can't work in paediatric palliative care if you're not prepared to be flexible to the point of your own discomfort, because in actual fact, it's your journey as a family. And, of course, there are baseline ethics that you're not going to cross, but there are other things where you've got to be able to tolerate discomfort and ambiguity, because in the end, personally, it's not about you. It's about going to where that family is and what they need to live with, what their time with their child is structured by. So it is about, bringing your wisdom and experience and listening, but also about letting go and just supporting anyway.
I just want to stand up and cheer and give you a standing ovation there, Sarah. I think that's so powerful. And a lot of my work in educating healthcare professionals is to give them the idea that they are a guide rather than the hero in the story. And the description of a really powerful guide is the balance between expertise and empathy and compassion and the ability to listen. And if you have those things, expertise and empathy and balance, then you can be the most powerful partner and guide for that journey for them to walk through. But you don't have to hold it. You don't have to carry it. You're just there with them, giving all of your knowledge so that they can then transform through that discomfort, through that pain and conflict. But you said that beautifully. Thank you, Sarah. Tim?
I think one of the ways that I've come to understand that is about our position to be proactive but not prescriptive. And I just think that builds on what everyone else is saying. And you gave the example early on about, is it the right thing to prepare for a funeral while your child is still alive? It's such a shame that there wasn't someone there who might proactively have said, explored with you that might be a thing you want to do, but not prescribed that you should do it or shouldn't do it, but have a real conversation with you about the variety of stuff that might lie ahead of you. Because I do feel like in palliative care, there are lots of potential regrets for people's future lives about how they manage things. And so that proactive guiding role that you talked about, I think has a place, so long as we're helping people then make their decision about how they want to go with it. And sometimes maybe looking backwards and reminding them how carefully they thought things through, even if they do have a few things that they thought they did perhaps differently, would have wished they'd done differently or whatever. But yeah, proactive, not prescriptive.
Awesome, Tim. I love this. And I remember Sarah, you said, I don't have any catchphrases about paediatric palliative care, and I feel like we've come up with quite a few of them today just in this discussion. So if anyone's taking notes, there's a lot of good wisdom here. I'd now like to change pace a little bit. I'm going to introduce a video that's been produced as part of the work undertaken for the Paediatric Palliative Care National Action Plan project, Demystifying Paediatric Palliative Care. And in this video, two mothers share their personal paediatric palliative care stories describing their initial reluctance to accept the support from the paediatric palliative care team. The video explores the journey of acceptance, relationships, reflection, and ongoing support.
When palliative care got raised, I couldn't fathom it. I was like, why? Just no. Because I didn't understand. I didn't know who they were, what it meant.
I didn't know enough about paediatrics to know that it's different. This is about living. This is very little about dying.
And it's about being in the moment. It's about making memories. It's about hope.
When we meet families, we'll often say to them, unfortunately, we can't change the outcome, but what's important and what we can do is change the journey and try and make their experience and the experience of their child that bit smoother.
Palliative care have the ability and the power to empower us as parents to be able to then see that it's not just medicine, it's not just a box of medical needs, there's a child here, and they tell everyone, around the team. So they're not just educating us as parents, they're empowering their teams and their colleagues. And
it filters out into the community-based supports as well, and it's worth its weight in gold. Often you can feel like you've got all this information coming at you and being shouted at you almost, and you can feel like you're screaming from the rooftops, but you're not being heard.
And when paediatric palliative care came in, everyone stopped and they listened.
The team are able to be that central point that's there to help you be heard, empower your voice, and help reframe and refocus the team around what's actually important. What's the best outcome for this person, this child, this family? We had this little bubble of life before the diagnosis where we were new parents learning how to be parents and living in the bubble that is a newborn bliss with all the hopes and dreams of life before us and what that pathway may look like. And then Mark was diagnosed at 5.5 months.
The night that Zia got her seizure, and I remember talking to one of the ED consultants and I said, does this mean she's going to die? And she said, I don't know. And that's an awful feeling. There's something really wrong with my child and I don't know who to tell or who to ask for help.
My job is the most amazing job. It is the greatest privilege to care for families. We see people at their very best. We see the very best of humanity. We see people who are able to continue to live and thrive after their child has died.
Watching your child die is the most painful experiences that anyone can ever go through.
It is a loss like no other.
Palliative care played a massive part in cushioning that experience in a way that was still meaningful, respectful, and provided dignity.
That love and that effort and that ability to just really see what needs to be done to support us in that moment.
One thing that my husband always wanted to do was to just take her out in the sun. We're finally in spring, can we do that? And she was so critical and she said, how important is this? And I said, so important. And she said, let's get you a bed and you're going to take it out in the patio. It was a couple of hours before she passed. How else can I remember my child's last few hours? It meant so much, at the time. Sorry.
Mark is a beautiful soul who taught us to look up through the trees and see the light through the shadows. And that no matter how hard things get, the light always finds a way through. And I think, in a way, palliative care do the same thing.
No matter how short or long life is, it's worth going to speak to palliative care. And it's scary and it's a complex layer of emotions, but I can guarantee you that what comes after that is going to be beautiful and amazing.
And life-changing.
And life-changing. Take that one small step and they will catch you for the next step, and then they'll hold your hand through the whole journey, right till the end and even after, because there is no end.
Forever grateful.
Grateful. Yeah.
Forever.
Yeah.
You can see that these mothers are so passionate about raising the awareness of paediatric palliative care to assist other families walking this path. Paediatric Palliative Care, NCA, together with Paediatric Palliative Care Australia and New Zealand, PAPCANS, have been funded by the Australian Government for the Paediatric Palliative Care National Action Plan project. This 3-year project commenced in July 2020 and will end in June 2023. Ryan, I'm going to jump to you again with this question. What do you think a national approach through the Paediatric Palliative Care National Action Plan project will bring to enhancing paediatric palliative care?
The biggest thing in a nutshell, I think, is to have a national voice, so to speak. You talk about all these amazing places that we have in Australia. Obviously not as many as some other countries in that have, but having a national approach and being able to share that from a national point of view, and how and collectively look at all the different reasons and needs that these children have across their lifespan and things like that. I think that's a big step forward, and that's been amazing that they've been able to talk to families, to health professionals, to experts, to everyone, to try and get that action plan going and talk about things such as terminology, which you've brought up, certain words that you just, unfortunately do get brought up and things like that, and how that should be spoken about. I think that's a really, for me, as a father who's lost my son, but now championing a charity and trying to champion these places. That's been a real big thing for me, is actually having a united approach.
And just another follow-up question, Ryan. I love how you've said that. How do you find that as a consumer yourself, as a father who has lost your son, how has sharing your own personal story and experience and being part of this co-design process, how do you think that will lead to quality improvement in paediatric palliative care?
It's a tough one. I mean, obviously you always talk about your stories, and people say, you want to be vulnerable, and I always believe being vulnerable, that's the best place to try and move forward and make growth. Because when things are rosy, life's easy. There's grass on both sides. You just, why change anything? So it does make it tough. But I think, it's talking to the people, families like us, and I think Sarah discussed on that, and obviously with Lisa around, families, they're the ones who are on the front line, so to speak, who are dealing with this and hearing those journeys. And if people are able to tell those stories, I think that makes a big impact on what some families want and what some families don't want. But understanding that everyone's different, but just because they're different in what their needs, we can still collectively, approach this in a really good way. So I think that's a good thing in regards to telling the story, and why we keep telling it, to try and inspire and go, well, hey, they are fearfully and wonderfully made, these lives. They may not be living a full life, what people would think a full life would be, until the age of, they like I said, that they get old and stuff like that. But to us, they still are a full life, and they deserve everything from that point of view. So I think hopefully that's where we come from that essence, as the frontline families trying to talk about it.
Yeah, I love that. Thank you, Ryan. And I found, even in my own experience with the work that I'm doing, the families, when they are listened to, when they can share their stories, healthcare professionals and everyone involved in that whole healthcare space really benefit, because it connects them to why they even became healthcare professionals in the first place. Like, they really want to get back to the essence, as you speak, the heart of care, and that's listening and sharing stories and being there with each other and having that expertise and being able to use your knowledge to impact a family in some pretty incredible and powerful ways. And so thank you so much for your work and for your story, Ryan. I'm wondering, Sarah, if I can just jump to you for a moment and just see if you'd like to add to anything that Ryan has said about the national project.
I think one of the things that the national project has allowed us to do is something that in paediatric palliative care has been evident for a long time, which is the voice of the parents who are in their 20s and 30s and have a different view of the healthcare system and a different demand, and so instead of the 1990s consumer involvement, which was often presenting pretty much a half-written case to consumers to get the rubber stamp to say, oh, yes, that's a good idea, where co-design goes further and takes more time and costs more money, is because what you do is you put the consumers at the front. And what families have to say to us and what other healthcare professionals that we work alongside have to say to us, what the charities have to say to us about what really matters, even though it may be an inconvenient truth, has actually informed into this project. And so we've actually had the time and the money and the space to properly, generously ask what actually makes a difference to you in this. And that's been fantastic to actually do that. And it has at times in the project pulled us up short and gone, whoa, that's new. Or nope, that's not going to make the difference we thought it would. And that's been amazing. And to think about what are the influences we need to think into the areas that aren't specialist paediatric palliative care, but still have a huge hold over families and are part of their overall experience. And it's been scary to look at some of that because it's a lot of work that needs doing, but to actually be able to not be too scared to pick away at that, knowing that we have a national action plan that we can feed that into, because sometimes it gets a bit scary to stop and look at something that is actually going to dig up a lot of work and a lot of worry that it's not going well. But if you have some faith that you've got somewhere to put it where it will be worked on and made a difference, then maybe you stop being so scared to ask. And I think that's why people sometimes have found it hard to ask consumers up front, because they're a little bit scared about what the families might say that would be hard to deliver.
Yeah, wow, that's a powerful observation, Sarah, and I think you're absolutely right there. We are so afraid of asking that we don't ask, and then we stay stuck in old ways. But asking powerful questions, you end up with powerful answers, and often that's where you end up being led to go, and it can only be good from there on in. And I know that Tim and Lisa, you were also involved in this project. Can you, Tim, I'll go to you first. Can you share your involvement in the project with us?
Obviously through my ongoing work in the community, and really what I've done is I've participated at, I think, each point where there's been opportunity to have input. So very early on some surveys, but then moving into there was grief and bereavement resources roundtable and action planning workshops and discussion paper consultations and opportunities to just pick up the phone and ring the team and have a chat about things of importance as well. So I think it's been grabbing the opportunities that have been presented to get a wide voice, make sure that to bang my little drum, that community organisations, not just specifically health organisations, have a voice in this. Not as important a voice as the families by far, but a voice that we do want to have there, because so that's been my involvement, and it's been a good involvement to have and a welcome one. I think I feel as if it's been welcomed.
I hope so too. It sounds really, really powerful and really interesting. Thank you so much, Tim. And Lisa, tell us about your involvement in the project.
So very much as a participator, in terms of, being involved in workshops, etc. But I was just really interested by what Sarah was saying around that sense of being able to, it kind of gives people an ability to ask questions and to put the information somewhere. And actually, even myself, in some of the discussions that we've had, I've said, oh, I've seen this little bit of information, and you kind of start to send things in. And so there's that sense of a building of a repository of information that is there. So, I think in lots of ways, that sort of, it's not just around the consumers, it's actually also around the professionals kind of feeling, oh, I wonder if they're going to be looking at this, and actually this might be a really interesting thing for the team to have a little look at. So yes, but very much just a participator in the plan more than leading anything.
Yeah, I love that we need participators as well. I'm going to ask you a follow-up question, Lisa, and I'll jump to you, Sarah. But Lisa, what do you think the barriers are that need to be overcome to rectify some of the challenges in the paediatric palliative care space? And maybe you can identify some of the challenges that you think are most present.
Look, I think one of the challenges that we have, if we look at, say, a group of conditions like cancer, what happened is cancer is made up of lots of very small illnesses, but they actually worked together and fundraise together and raise awareness together. And so people talk about childhood cancer. And I think one of the problems that we have is our numbers are always going to be quite small. But I think there's a real ripple effect because the numbers of children are small, but then we have that family surrounding them that consists of siblings, parents, grandparents, aunties, uncles, all of whom have health consequences, social consequences, community consequences. So actually, it's not a small pool. It's actually a much bigger pool. But I think one of the challenges that we have is sort of the very small numbers, and how do we as groups work together? So I think actually the National Action Plan is one way to support that. And we see other initiatives like within professional settings, such as education initiatives like the QACA, the Quality of Care Collaborative Australia initiative, which again is trying to help and support people to work together and to share. One thing that I feel really strongly about is working across organisations. We are siloed. So, I've said it a few times, professionals, so I kind of think about health and education and disability. And I just think if we could do some better interagency work and work well with our communities. The concept of compassionate communities is a beautiful concept. And we have a few that are working here in the southwest of WA. But I sort of feel that we still silo working because we actually support families in an organisational way. We talk about child and family centred, but the walls of the structure of the organisations that we work in stop us. So that's a real barrier, and I don't know how we solve that one, but I think that would be an amazing thing if we could do that.
Yeah, a lot of agreement there, Lisa. And Sarah, with your long-standing time in the sector, what do you consider have been the key challenges in paediatric palliative care?
I think we need to do something about the fear around referral. There's nothing more devastating working in paediatric palliative care to hear a family say, "We needed you 3 years ago, where were you?" And to understand that there were all sorts of barriers, and that there are some of our mainstream colleagues who stand there wringing their hands in front of a family saying, "Would you mind meeting the paediatric palliative care team?" I think, we could do better. No, we don't need a name change. Someone said, "Oh, if you called supportive care, it would help." And it's like, well, we're not a whole lot of bras. We're actually palliative care, and supportive care would just take on the name. What we've got to do is deal with that we really are about the living, that we really are about keeping hope, and there's some work we can need to do around that. I think fear of the unknown is really difficult for people, and the mainstream capacity of our colleagues in the communities, in the community organisations, in other healthcare streams, etc., and thinking about how do we work on helping those people feel comfortable to work with these families and have less less of a sense of fear, allow us in to work alongside them, to support them, and know, if you've got to have a conversation with a family and you want to raise this subject, why don't you give us a call first, because we can boost you up. That sort of thing, doing that kind of very much that awareness of, and we're not tapping into enough, I agree, those barriers to trying to work out equity issues for families, what they can really plug into. We've got massive inequity issues across the geography of where does someone actually live and what's really available, the culture they come from, the social platform that they're living in, the attitude of the healthcare professionals they've been working with can create a huge inequitable platform. And what are those issues, and how do we actually not just roll our eyes every time we see it, but how do we actually start collecting some data that informs us into what are some of these groups and how do we get to them and ask them, what do you need?
Yeah, beautifully answered, Sarah. And I think that links back to when we're talking about the power of multidisciplinary teams. And Tim, I'm going to ask you a question around this because we have talked a little bit about this. Can you explain what a multidisciplinary team means, and how that it's beneficial for families and service providers, and maybe especially given that inequity, potentially speak to the power of potentially that a multidisciplinary team could have to mitigating some of the inequity involved in this space?
I'd like to answer that kind of in a double-barreled kind of way. I'm really glad we're still sort of focusing on family-centred being at the centre and the multidisciplinary team being around that. But I'll talk first about multidisciplinary, if you like, if you don't mind, and then I'll talk about team. If good palliative care, good paediatric palliative care is about the care of the whole child and the care of the whole family, then there are obviously so many different things within that: physical, biological care, emotional care, social care, financial, cultural, spiritual. You could keep listing and listing, and it seems obvious, doesn't it, that that's not something that one person can bring most effectively. To have a multidisciplinary team, a team of people who bring different relevant disciplines, different relevant expertise to that wide range of parts that make up whole of person and whole of family care is important. So, that's what it is. Typically there's a core to a multidisciplinary team in palliative care that would be specialist doctor, specialist nurse, specialist social worker, and then potentially others as well. And in fact, often there is a kind of small core group and then additional people who are added depending on the needs and the circumstances of the child. And, as soon as you start listing disciplines when you do this, you always accidentally leave someone out: psychology, occupational therapy, child life and play specialists, education professionals as well. It's kind of getting the hive mind of people together, because, the breadth of expertise, the breadth of knowledge, is surely a resource that's all the better for that family that is in the middle. And I think that is the key thing: family in the centre, team around, and that team may not come from just one place. It could come from multiple different organisations, because not all organisations have an entire team. Not everybody lives in a place where a full specialist paediatric palliative care team is going to exist. Lots of people don't. So the team might be something that is brought together from more than one organisation. And I would like to flag as well that local community, family themselves need to be seen as part of that multidisciplinary team. Family brings their own expertise, an expertise that no professional training gives you. That the family's expertise can only come from being that family. We do hear from families how much they value talking to other families who have been through this, but each family's an expert to themselves. So I think that multidisciplinary team needs to be looked at broadly like that. But the other thing, the reason I wanted to kind of talk about teams separately is that can be an overwhelming number of people I've just listed, and the aim is to empower, not burden. And so that group of people, that multidisciplinary team, needs to work really well as a team. You know, with the family as part of the team, there needs to be really good work done on having a shared goal, really collaborative, or shared goals, there's really one goal, really collaborative ways of working and planning, respect of the different expertises, especially respect for the expertise that the family brings, coordination, good communication, all those things that make teams work really well. So yeah, multidisciplinary and team, two elements of the story, but in that way, when that is done well, it's really, I feel it is a great resource for families, more comprehensive resource than any individual practitioner, specialist can bring. And of course, at different times, different expertise will need to be more dominant, will need to be more involved depending on what's happening for the child or for the family. And so it's important. I think it's also important though for the professionals to work with colleagues with different lenses, different perspectives. It creates such a rich environment in which to reflect and think carefully about your practice and what you're doing. And I can certainly remember a number of quite long drives sometimes when we were doing outreach to families in the community where there's doctor, nurse, me as social worker, the drive out with lots of planning and thinking and wondering about what we're going to do, and the drive back with lots of reflecting and wondering if we did it okay and what did we learn and what can we learn from each other, what do we need to bring up next time. But also that support, because it's work we all do because we're passionate about it and we love it, but it can come at a cost as well. So there's that collegial support, that ongoing learning. So I don't think there's much you can say against the multidisciplinary team if it is a really good team and not burdening the family with too many people and too many tasks.
Yeah, really well said. Thank you so much, Tim. We've got another video to showcase today, and it's just as impactful as the last one. Last year, Palliative Care Australia commissioned Moonshine Agency, an award-winning impact filmmaker, to produce the definitive documentary about palliative care. And this is one that unites the moral and economic arguments for palliative care into an accessible and powerful narrative that ultimately assists Palliative Care Australia's efforts to ensure that every Australian has access to palliative care.
So to get him into hospital and then see this poor child come from almost a slightly whimpering silence to just this beaming, mischievous child, literally within half an hour, it was extraordinary. And that's when you think, my God, that's what palliative care can do. So if I look back to the time before Marmaduke and afterwards, I probably had a conventional life, and it was probably accompanied by the same sort of fears and anxiety that everybody else has. I think a lot of day-to-day cares and anxiety and fears got in the way of good living. And it's not just the loss of somebody that changes your perspective. I think just the richness of the journey, that understanding of what happens when you're present, what that uncovers for both of you, because you both gain something from it, changed my life. It's an odd one talking about grief because a lot of people don't get it. Well, I remember when Marmaduke died, I had a degree of acceptance around that. I know a number of friends found that challenging, but I think it's interwoven with that sense of gratitude in that it meant I could celebrate the stunning relationship that we had, that amazing opportunity to share a journey with a son who was so full of life. We just focused on each day and each moment, actually. It sometimes came down to each 5 minutes, particularly towards the end of his life. I do remember a gut-wrenching fear there was a stage when the worst possible thought was that he wouldn't be cured. And then very quickly, he became terminal. And so then you're juggling, he's dying. But you don't know when, you don't know how necessarily. And so by the time you realise the treatment isn't going to work, you've almost accepted, right, it's going to be terminal from here. And my focus then was very much, what does he need? When you're so present, so much joy is available to both of you as a result, that you have amazing gratitude for that relationship. And so even though he died and we lost him, perhaps I choose not to dwell on the loss. And that sense of gratitude comes up so naturally because I just fill with joy and smiles when I think of him because of that amazing connection that we had and what we shared. And we were open to it and we didn't block it and we didn't let fear get in the way and we didn't bury ourselves in the past thinking about what we'd lost, and we didn't bury ourselves in the future in terms of denial, thinking about, oh, it's going to be okay. We actually just accepted what was happening and tried to get the most out of each day that was given to us. And those days became weeks, became months, so it was actually a beautiful journey. That amazing environment, that cocoon of love that we created around him, meant that we had a beautiful series of weeks as he declined. So I think that processing of grief is highly individual. And I think where there's a long medical journey, it may happen slowly over time. That possibly meant I was better able to feel the gratitude and acceptance when he died, because I'd been processing this for so long. I think gratitude, if I look back, it's not something I sought, it's something that developed. It's funny when I look back, I might say, oh, the way we chose to be with Marmaduke, but in a way I think it was the way he chose to be with us. He was so mischievous but so alive. He demanded my presence, so I had to be focused on him, and you become everything from nurse to clown, because when you're being present with someone who's at end of life, everything else does just fall to the wayside, and it gives you a different type of perspective, because suddenly work isn't that important, that email isn't as urgent, that phone call isn't as critical. What's important is those eyes staring up at you and what they need. All the cliches of don't sweat the small stuff, they're all real. Go home and hug your children, go home and hug your partner. I suppose it goes back to the French author in The Little Prince. What's truly important is invisible to the eye. And that was our journey with Marmaduke.
And you will note that this film has already attracted a number of corporate sponsors, but it's not too late to get behind this project. If you are interested, please reach out directly to Palliative Care Australia. Now, Sarah, I'm going to jump to you. Having listened to Simon's story, which is incredibly moving, I remember crying when I saw this as well. What is needed to continue the progression of paediatric palliative care in Australia? Because we're obviously already getting a lot of it right, but what more needs to be done? What gaps have you identified?
Look, it's the same as whenever you ask one set of, questions, you're going to come up with a whole lot more to do. And it's maintaining that bravery and commitment to say we will just continue, improving and asking. So I think a lot of it sits on that, is that ongoing commitment to that. And of course that means resources. And I think too, keeping up that belief that, sits well with the It's Your Right theme, which is that, these short lives really matter. And it is their right to live them the best they can. And yes, that is resource intensive. And yes, we have to invest in a large community in order to do that. But, keeping up that character that goes with it and that commitment to the families to truly hear them, not just what we want to hear, but really hear them. I think having responsive specialist 24-hour support for families is really, really important, because there's a lot of stuff that is very science-based and very much in the sort of the experienced art form, and that all families need to have access to that, even if it's a collaborative thing. We need to make sure that we get to the families we should be getting to in the right timely manner, and we're not. And so, being able to work on that, and what are the barriers, and how do we not even just, I think we've got a fairly good idea of what the barriers are. We actually finally need to address them and have the actual resources to do that. I think understanding and providing intensive and sustainable bereavement support for families. This is a different context than when Nana dies, and actually being able to have the proper resources and ongoing familiar follow-up for families from qualified people is a really important area to get into. And I think, working on our data and getting an idea about, in this small group, looking nationally at the data and going, what is it telling us? What is it telling us about our work? I think family-centred information and how families want to receive information, that changes. It's a dynamic thing. I wouldn't have thought podcasts were anything even vaguely interesting to listen to years ago, but now families are saying hearing another mother say that meant 10 times more than when you said it. Listening, moving, changing with the times. What does an adolescent want to hear? How do they want to hear it? And getting up with it. We were so scared of doing FaceTiming with families. Oh, no, you can't do that. It's not a safe platform. But a family saying, I can't bear to just talk to you on the phone. Please, can we FaceTime? Why aren't we listening? We loosened up over COVID and started doing things like art therapy online. What does it mean to loosen up and really get in there? And I think, bottom line, we have to be able to provide tailor-made, rapid and thorough support for families, for all of them, no matter what stage they're at, no matter what is affecting them, no matter what dimensions they come with. We need to be ready to do that. And I think moving forward, just keeping on going with that and being ready for those circumstances where we have to do something a bit funky, a bit different, and being ready to be different, being resourced to be different, and brave enough and supported within our platforms to actually really go there.
Really great ideas there, Sarah. Thank you so much. And that speaks directly to Lisa's spirit and essence of creativity as well, and not being afraid to try new things and just experiment a little bit and listen. I love that so much. I'm going to ask you a question, Tim, and then I'll ask all of you this question. But what do you think can be done over the next few years to improve awareness of paediatric palliative care?
I'm so glad you're asking everybody that question, not just me, because it's such a big question. The answer's got to be multifaceted and multi-layered, but starting point is obviously being clear about the issues. And of course, Lisa spoke to that before, being really clear, talking to families, knowing what the issues are. But then I think it's got to be multifaceted. There has to be awareness targeting at funding bodies, government obviously, but in the not-for-profit space, philanthropy as well, to get funds to address the inadequacies and the inequities that we all know about and we've talked about just a little bit today. There's got to be work around education and training. That's professional education and training that professionals have access to when they're doing their initial training, but every bit as importantly, ongoing professional development and easy access to people with expertise and to resources with expertise as people's in the health spaces sort of career might gradually move them towards palliative care. It's not necessarily where people start. So ongoing professional development, there need to be all of the resources and access, and there's great work being done in that area at the moment, of course. I think we need to do a lot of work, and we've heard a little bit about this as well, around clear referral and sort of liaison consultation pathways for specialist palliative care services. So generalist services can connect in, make referrals too, but connect into the expertise of specialist paediatric palliative care teams. But really importantly, I think there's a big challenge, of course, is that it's a topic that we know people shy away from. For all the fearful reasons we've talked about before, and that situation does harm because it perpetuates the lack of knowledge that's out there. And I can't help but think that the main answer to that challenge for raising awareness is hearing real stories. We've watched some powerful videos today. We've heard from you, Rachel. We've heard from you, Ryan, and the stories that you share are they're highlights of conversations like this. They're the powerful stuff. They're the stuff that really gets home, but it celebrates. I'm hearing celebration of all of the children in those stories. I'm hearing celebration of the resilience of families. I'm not just hearing the things that everyone's scared of. So I feel that real stories, increasing the visibility of people who are living with life-limiting children, who are living with life-limiting illnesses, making sure that they're included in our community, that they are visible, that who they are is important. And for me, a final point is, I think that we need to not just hook this up with lots of little organisations around different conditions and illnesses getting together, but I actually have a sense that there's something in the idea of us connecting this to a story about children's right to well-being, to the best life that they can live, that all children in Australia, you would hope, we would aspire that social policy and health funding and everything puts that in first place, because it's something that pays back. And I think palliative care, paediatric palliative care, that sense of the well-being side of that, we've talked about it plenty today, but it's not what people think of at first. And hearing, how parents have worked so hard to make sure that their children have their best life. I think those stories bring us back to a picture of children thriving, living their best life. And I feel that's a message that can connect to people, perhaps cut through some of the fear, but give people the courage then to look at, they've got to have courage to look at the stories, to deal with their fears. But if the goal is best possible well-being for these children and young people, then maybe there's a hook in that we can hang those other messages off. I think it's a very challenging question, though.
Well, I just think you answered that spectacularly, Tim, to be honest. I think you spoke so much wisdom to that big question. And I agree, it is the stories, because I think if you can look after the families so well, then they end up on a trajectory that can have hope and courage as well. Like, I'm thinking about you, Ryan, and your journey, and we're going to hear a bit more about Rio's legacy in just a moment, but it changes the entire story, not just for the moment of bereavement or grief, but forever. Like my work now, I'm an ex-wedding and portrait photographer, now teaching healthcare professionals the importance of language at diagnosis. And it's an amazing job. I just made it up myself. I didn't know it was a thing that could happen, and I'm loving it. And there's so much joy in my life, despite having this awful thing happen. Like, the thing that we fear, I always believe that there is a beautiful side to our pain and our fear. We just have to move through that, and when we move through that with a team that can support us, that can show us that there is a beautiful side to that unbearable thing, then that is truly transformational on every level of an individual, a family, a culture, the world. That is the work that's been done here. So this has been an incredible conversation, but I wonder if any other of our beautiful panelists want to tackle the question, what can be done in the next few years to improve awareness of paediatric palliative care? Sarah or Lisa, have you got anything to add? Yeah, Lisa.
I think, again, it comes back a little bit to small numbers. So we all know that it's very easy to go above and beyond and to keep going above and beyond. And the sorts of people that work, so my colleagues, I have the most beautiful team, and they all go above and beyond. And we never draw the line in the sand and say, we're not doing it. So people will work all crazy hours, etc., and battle and fight. And we actually do it for the individual child. So I think it's something about harnessing that to work, not for, you would be working for the individual child, but working for the whole as opposed to the individual, because I think we're not very good at that, because we're so busy on the ground helping that we're not very good at coming back and stepping back and saying, you know what, if I focus the same amount of time more organisationally, it may have a more long-standing impact, but this individual child may suffer. We can't do that. It just isn't within our ability. So I think that's a problem. But I was just, when you were talking, Tim, I was thinking, when have I seen paediatric palliative care on a soap opera or in a theatre play or routinely in some, a movie or whatever? I can't remember, and I'm sure someone can come up with one, but it's not common. And so actually we have a hidden population. They are hidden, and people are fearful of lifting the veil and saying there is a whole group of people that need some additional help. So I actually think that we need sort of some focus in that way around the normalization of this. This is not society's failure. We can make this society's success, but paediatric palliative care is not society's failure. We need to make that message very firm, I think.
So powerful, Lisa, like a drop the mic moment. And again, another really tight little phrase that will stay in people's minds. And I think that, again, like you said, it is a fear, and so we don't address it. But yeah, powerful share. Thank you so much. Now, we're coming to the end of our discussion, but there's a few little things that we want to touch on before we wrap this up. And Ryan, I'll go to you just so you can share with us what does Rio's Legacy do, the work that it's doing. Tell us about your work.
Yeah, when we went to Bear Cottage, we found out there was only 3 hospices in Australia, and you're here in the UK, there's 50 or more. You start to sit there going, okay, why is that the case? And that was the crux of why we started Rio's Legacies, was to try and build more awareness, but also see if we can build more hospices. And I know that's a big thing to do, but build more hospices nationally, wherever the need is, and to support everyone across this great country of ours. So over the course of our time since then, we've done a few things along the way and a few challenges. I've done a few little challenges here and there to try and raise awareness, and I'm proud to say that we've been part of that. Obviously we've been part of things. Rio's story is a case study in the Catholic education's curriculum across 12 schools in New South Wales, so south of New South Wales, I should say. So like Wollongong down, so there's about 12 schools down there. They use it as a case study based on one of their stage 6 units, which is amazing. And they're talking about Rio's story and obviously the compassionate approach, and obviously getting that in we've been amazed that's been able to take off. Obviously we've had fundraising nights to try and raise awareness and to celebrate fun. So a night in Rio was a night that we had where we had Brazilian dancers come and my wife wanted to have Brazilian dancers and have a night of drums and celebrating, and that's what we did. And everyone said, and obviously we had fundraisers and auctions, so we did all that. So it was obviously when you've got a son named Rio, and you can sort of fit that together. So we're able to have that fun aspect, and obviously get that message and enjoy each other from that point of view. So we've been blessed to be part of those things from that point of view. And obviously I've done a few challenges. I've run from Melbourne to Sydney. I rode from Adelaide to Sydney, but via Melbourne and Hobart. And we've been very lucky to have some people in place to raise awareness. People often sit there going, "What's this guy doing?" Doing all those Ks, but that creates the story. People then go, "Well, hey, what's he doing this for? Why is he doing that?" Not easy, but easy challenges along that way, because I'm a type 1 diabetic, so that adds to it as well. But we've raised a lot of awareness and funds, and really proud, obviously, with Lisa and everyone over the WA, because they're building, we kept saying the WA's first hospice and the fourth one, I keep saying, in this country, which is amazing. And we're proud that we were part of that. We were able to donate over 100,000 as a charity towards that build. And obviously the team that they have over there and what they're doing is amazing, and we raised over 120,000 for that challenge that I did. It was some tough conditions, I must admit. WA definitely gave me some tough battles. I'm trying to do that. But yeah, that's our legacy. That's our journey. That's Rio's legacy now. Rio's my story, but obviously it's now trying to champion these other families and tell their stories and be that voice that everyone is here. And that's what it is for us. And that's the legacy that we'll have. And, and we'll keep on championing that as long as we can. And we've raised, just under 600,000, but we're hoping, if people can't raise, it's all about just have the conversation, just talk about it. It's okay to talk about this stuff. And, are you aware of this? No, I'm not. Okay, well, we should be. So that's in a nutshell our journey, and we'll keep going on.
Incredible. Very much, Ryan. Amazing work, and it is such an incredible legacy. And just to finish off this incredible discussion, I challenge you in one sentence or less. What would you like people to take away from this discussion?
The challenge is to, start the conversation or change the mindset. I think that's a big thing around palliative care. If you're saying, I don't know what to do, that's one thing you can do, is just change your mindset and go, okay, I'm happy to approach that subject.
Fabulous. Thank you, Ryan. Tim?
I guess if there was one thing I was going to say, it would be that I hope people, be they professionals or members of the community, might take away that this is about meeting families experiencing paediatric palliative care right where they are, having just the capacity to listen to them and take their lead. If there was one thing to take away, do that.
Lisa?
I would just want to say that paediatric palliative care matters, but we can do more if we work together.
Beautiful, Lisa. Thank you. And Sarah?
Look, I think it's been said, but I think I would say that these short, precious lives matter, and we would like people to join with us to help serve these families the best way we can.
Fabulous. I love it. Thank you so much, Sarah. And thank you so much to Sarah, Tim, Lisa and Ryan for such a great discussion. This topic is so important, and it has been such a pleasure to facilitate this webinar today, and thank you to you for joining us as well. To formally close today's proceedings, it is my pleasure to introduce Professor Mira Agar, Chair of Palliative Care Australia.
On behalf of Palliative Care Australia, thank you to everyone who joined us today for this really important discussion during National Palliative Care Week. A big thank you to Rachel Callender for hosting today's event and sharing her special connection to this topic. Another big thank you to each of our panellists for their incredible insights and perspectives. Today's event has highlighted the many challenges and successes in paediatric palliative care and explored pathways to provide the best possible care for children and families. We hope all of you got a lot out of today's conversation. I want to take this opportunity to acknowledge Senator Katrina Billick and the Honourable Nola Marino for their support and dedication to this Parliamentary Friendship Group in their roles as co-chair for the past 3 years. We look forward to working with you both in the future. Today, we featured the trailer for the upcoming Palliative Care Australia impact film. It's a project we're really excited about. This documentary will help showcase palliative care and how it benefits so many people in our community. We have a number of partners on board already, and if you or your organisation would like to get involved, please get in touch with us. There will be further details in the description box below. Until our next Parliamentary Friends event, please stay safe and stay well.